I think we can go ahead and get started. 2 minutes past the hour. Hello, everyone, and thank you for joining. This is the SWOG GI Committee meeting. We have a couple of hours, and we're hoping that next time we meet in the spring that we will be in person. What I'd like to do is thank everyone who's joined today, especially people who are new to the committee, and we look forward to hear your comments and contributions to regarding the studies we're going to be discussing. Please mute if you're not speaking. The other thing is that we have a chat box, so feel free to send any questions, comments, greetings. We will follow each one of these, and then we go forward with the presentations if there are no discussions. Can we go to the next slide, please? These are my disclosures. I don't know why I've been asked to give disclosures and the rest haven't, but these are mine. Next slide, please. I'd like to introduce you to Dr. Kurian, Gabby Kurian, who is now the vice chair, and she is working on the committee replacing Dr. Kathy Ang, who's been promoted to be the co-chair of the GI Steering Committee of CTEP. We have welcomed Dr. Kurian's decision to join the committee and step down from being the co-chair of the Pancreatic Task Force. Dr. Christopher Ryan, who's been with the committee for a long time, and he's the executive officer, and I can tell you that he's been a great help for us in terms of developing the studies and opening the clinical trials. Thank you, Chris, once more again today. Next slide, please. I also like to introduce several of the key people in the Gastrointestinal Committee. You will be meeting with the subcommittee chairs, but here are people who really make the committee work in terms of the support we get from pathology, Dr. Mary Kay Washington, translational medicine, Drs. Lenz, Liu, and Catenacci, our surgical colleagues, Dr. Berman and Dr. Ahmed, imaging, Dr. Shields, and radiation oncology, Dr. Kachnik. Next slide, please. Other members of the committee, Cancer Prevention Liaison, Dr. Zell, Cancer Control Liaison, Dr. Barzi from City of Hope, Dr. Bushakter, who is the Community Liaison, and he's at the Kaiser Permanente, and then Dr. Mohammed Salim, who is Community Liaison from the Levine Cancer Center. Dr. Salim was my colleague here at the Karmanos Cancer Center. And then we have Dr. Horowitz, Community Liaison from Columbia University, Dr. Shen, Community Liaison from Penn State, Dr. Mark O'Rourke, Community Liaison, NCORP, and of the Carolinas. He's also an expert in palliative care medicine, and Dr. Jeremiah Lee Deniv, Surgical Community Liaison from University of Tennessee. Next slide, please. We also have Dr. Patel, who's in the drug development in phase 1. He's from UC San Diego. Dr. Flavio Rocha, who's a surgical community liaison from Virginia Mason. Dr. Suarez, who's our digital engagement expert from the Huntman Cancer Center from Utah. And then we have Dr. Jane Rogers, who's a pharmaceutical science liaison from MD Anderson, and Dr. Jason Reed, again, pharmaceutical science liaison from MD Anderson. Next slide, please. The Gastrointestinal Committee is privileged to have great statisticians, and we have Catherine Guthrie and also Shay Balazzi. And we also have Christy Klepko, who's our protocol coordinator, who does a lot of the work that helps to get the studies opened and or get them ready to be reviewed and then opened. Next slide, please. We also have our colleagues who help us in the data management and coordination, Sandy Annis, Siwan Gurung, Christine Magner, Jacqueline Skurlock, and Brian Zeller. Next. This meeting, the entire meeting of SWOG, is really coordinated by Courtney Will, who's been really has done a tremendous job in really getting everything together, and we are very grateful for her contributions and help. Without her, we cannot do this complex kind of Zoom meeting or virtual meeting. Next. This is our agenda, and we have a bit of a packed agenda, so we try to be on time. And I also encourage the speakers to follow that. As I mentioned, please mute your microphones if you're not speaking. So we'll start now with the committee liaison updates, patient advocates. Next slide, please. Again, we're privileged to have Florence Cortella and also Carol Siegel, who are our advocates on our GI committee, and I will let them say a few words. Carol or Florence?
Mute. We gave our detailed report this morning, and it was just a culmination of so many things that we're involved in as advocates. We've really enjoyed working on the committee, and we have a lot of modules, we have a lot of diversity, we have a lot of outside committees that we work with, you know, things like Kaiser, patient advocates, and it's just been a very rewarding experience, and we've learned an awful lot, and it's nice to be able to contact the PIs directly, and we've just are establishing a good rapport with all of them. So I don't know if Carol has anything to add, but those are my comments, and I appreciate being here. Thank you.
And again, on behalf of the committee, we thank you, Florence, and we thank Carol very much for all the efforts you put. Increasingly, your role has become quite obvious that we have to listen to you and work with you, starting from the beginning when we're planning a clinical trial. Thank you.
Thank you.
Next slide. Now we're going to talk about the featured trials. Next one, please. 2107, Dr. Morris.
Thank you, Philip. So yeah, to the group, I'm Van Morris. I'm on faculty at MD Anderson, and this is a trial looking that we expect to enroll and activate in early 2022. This is the S2107 trial. This is a randomized phase 2 trial looking at encorafenib and cetuximab with or without nivolumab for patients with microsatellite stable BRAF mutated metastatic colorectal cancer. So on the next slide, we have a little bit of background just about why we need to do this. So we know that, that BRAF mutated CRC is, these patients have, unfortunately, especially poor prognoses and poor responses to standard chemotherapy options. And while the Beacon trial published in the New England Journal following the preceding SWOG 1406 trial, was the first trial to show survival benefit with the targeted therapies encorafenib and cetuximab, and this led to an FDA approval for this regimen. As you can see kind of in the figure on the right here, the median progression-free survival, despite getting an FDA approval, was only just over 4 months. So while this was a step forward for our patients with BRAF mutated metastatic CRC, it was a baby step, and we need to do better and be able to offer, our patients better survival outcomes with novel approaches. So that's what SWOG 2107 will be an effort to do. And this is kind of based on some very interesting preclinical work, which shows that in cell models of microsatellite stable BRAF mutated colorectal cancer, when you treat these with targeted BRAF EGFR combinations, you may be actually able to flip the phenotype from an MSS status to an MSI deficient mismatch repair status. And if that's indeed the case, we may be able to prime these patients for benefit to immunotherapy by treating them with BRAF EGFR targeted therapies at the same time. And because we were interested in this question, we started a trial at MD Anderson looking at this combination of encorafenib, cetuximab, and nivolumab that is still enrolling its final patients on this study. But we're very encouraged by the safety profile for this triplet combination, as well as kind of the early clinical signal that we anticipate reporting in 2022, specifically for patients with MSS BRAF mutated CRC. So to better study this question, this is the reason for the SWOG 2107 trial. On the next slide.
Next slide, please.
So again, this is going to be a randomized trial where patients either receive standard of care encorafenib, cetuximab, or encorafenib, cetuximab with the addition of the anti-PD-1 antibody nivolumab. There will be a 2-to-1 randomization, so there's a 2/3 chance that an enrolled patient would have the opportunity to receive the addition of nivolumab to standard of care treatment, and we anticipate a total of 75 patients to be randomized and treated on study. We did get approval for CTEP for this past summer. The protocol has been written and it will be reviewed at the NCI next week. The absolute deadline will be that we expect to activate the study by July of 2022. But if we can get favorable feedback from CTEP, we are going to really push to have this open as soon as absolutely possible, for our patients, hopefully in early 2022, in order to, again, hopefully get new and better treatment options for our patients. On the next slide, I think we have study eligibility. So again, briefly, patients can have, adenocarcinoma of the colon or rectum. They must have a microsatellite stable, proficient mismatch repair, BRAF V600E mutated tumor, with 1 or 2 prior lines of systemic chemotherapy for unresectable or metastatic disease, prior treatment with a BRAF, MEK, ERK, or other anti-EGFR therapy, as well as prior immunotherapy, would render a patient ineligible for our study. And as you can see here, prior brain mets or other coexisting autoimmune diseases would also render a patient ineligible. So please keep this in mind in 2022 as you see these patients in the clinic, and we of course will keep the groups updated as we have new information regarding the status of this important clinical trial.
Thank you, Dr. Morris. Just to clarify, this study has already been approved by CTEP. We're just preparing the protocol, so it's a matter of getting the protocol completed, has a final approval by CTEP, and then we can open it. So I'm hoping that we'll be opening before July, maybe well before July, first quarter of 2022. Any questions? I do not see any questions in the chat box. Okay, thank you again, Dr. Morris. We go to the next study now. Dr. Chung, Dr. Vincent Chung from City of Hope. Go ahead, Vince.
Good morning. Actually, good afternoon, everyone. This is actually a different slide deck than the one I had actually sent. The one I sent was actually the ASCO GI presentation. But in terms of, this is S2001, which is a randomized phase 2 study of maintenance olaparib plus or minus pembrolizumab in patients with germline BRCA1 and BRCA2 mutation. This is again building upon the results of the POLO trial, which showed that olaparib actually improved progression-free survival when compared to placebo. So can we go to the next slide, please?
There's only one slide.
Huh. Okay.
That's okay. You can just go.
So going back one slide then. So this is, again, maintenance clinical trial. This was co-developed with the Alliance. So Mike Pishvayan at Johns Hopkins University is actually my co-chair. And this was activated in SWOG in December of 2020. So we currently, as of end of September, have 200 institutions, which are mostly community sites at the present time that have actually opened up the study. We are looking to, again, accrue a total of 88 subjects to evaluate the progression-free survival and improved progression-free survival in the control arm from about 7 months to about 11.7 months. So part of the background behind this is that in patients with germline BRCA1 and BRCA2 mutation, they are sensitive to PARP inhibitors, but there is actually inherent genomic instability in patients that have BRCA mutations, thereby increasing the potential sensitivity with checkpoint inhibitors. We actually did preclinical work looking at a genetically engineered mouse model with a BRCA2 mutation. And when you give the combination of a checkpoint inhibitor in combination with a PD-1, then we did see an improvement in survival in the mice compared to the single agent alone in the mouse model. And that's what kind of led to the development of this concept of giving the checkpoint inhibitor in combination with the PARP inhibitor. And we have seen that in many other trials in other different tumor types that there has been synergistic activity. So the eligibility criteria for this clinical trial is, again, patients that have germline BRCA1 and BRCA2 that is tested as part of standard of care. One of the things I've had many conversations with different PIs, and they have indicated that some of their patients are not wanting to get germline testing. Personally, I've not really encountered that very often, because as I'm talking to my patients, I'm telling them that the germline testing will be important to potentially identify additional treatment options down the road. Most of my patients actually do agree to do germline testing. But if any of you out there have any concerns or problems in terms of germline testing or don't routinely do it, I'd love to hear from you in the chat. So again, patients will need to actually undergo at least 4 months of platinum-based chemotherapy. So this would be FOLFIRINOX, FOLFOX, or gemcitabine cisplatin chemotherapy. They will have to show no signs of any progressive disease, and they should not receive any more than 6 months of chemotherapy prior to enrolling in the clinical trial. So the reason for the 4 to 6 month range is because we are wanting to get them onto the PARP inhibitor before they develop platinum resistance, because we have seen from previous studies that if you do have platinum resistance, they do not respond well to PARP inhibitors. So we're looking for that window of accruing the patients after they had 4 to 6 months of platinum-based chemotherapy. And the primary objective for this study is progression-free survival. We are looking to accrue 88 total patients, and we're really happy that you're interested in the study, and look forward to working with you in terms of accruing this difficult patient population.
Okay, so we have a couple of questions. One is saying that we did not open as we feared patient might be started on Gem/Abraxane prior to receiving BRCA results, rendering them ineligible. Allowing one cycle of Gem/Abraxane would really help. Can you comment on that?
Yeah, so that's a really, really good question, because there are probably about 50 to 60% of the patients that actually get started with gemcitabine and nab-paclitaxel chemotherapy. Part of the reason that we had designed it this way was because we had to follow the POLO trial. So to go through getting approval through SATEP, et cetera, we had to really follow the eligibility criteria that the POLO trial had actually outlined. I mean, I think this is definitely something that we can consider and discuss going forward. We would have to have additional discussions with CTEP regarding this. But yeah, I can see why this is a challenging. It's a very good question, and I think that it wouldn't make a difference in terms of response to PARP inhibitors or PD-1, but we did have to follow the eligibility criteria that they had utilized in the POLO trial.
Okay, so one more question. Dr. O'Rourke, who's saying that in my clinical practice, I have not, and he emphasizes not, encountered resistance to germline testing. We present germline testing as the standard, and virtually all agree, which will be same at my practice. What do you think? I mean, what is your impression?
Yeah, so in 2019, we added this to the NCCN guidelines that all patients with pancreatic cancer should get germline testing. So it is part of my standard practice. And I think that, in terms of most academic centers actually do this as standard of care for all their patients. In the community, because resources are less, I can see how there can be a little bit more challenge with germline testing, just because there's a lot more counseling that's involved. But I'm hoping that, moving forward, we could see more of the community practices actually doing germline testing as well.
Actually, it could be done in the community very easily, because in my practice, I don't wait for the counseling. I send the blood. When I first see the patient, I just take blood and send it for the genetic testing. So, and then if there is a positive mutation, then we refer them to the counselor. But thank you very much again, Vince. This great presentation. We next move to SWOG 2104 study, and I think Heloisa is on.
Yes, thank you very much, Dr. Philip, and thank you, the SWOG team, for allowing us to present this study on behalf of the NET subcommittee. And I shared this study with Dr. Ahmad. So this is a phase 2 randomized trial of postoperative adjuvant Nctn, Capecitabine, and Telozumab versus observation in patients with high risk for recurrence of pancreatic neuroendocrine tumors. And next slide, please. I'm happy to report that as of yesterday, this trial has been activated. So please consider opening at your institution. So what are these high-risk patients after resection that are high risk for recurrence? So taking into account several publications from the literature, and most recent a publication from the US NET neuroendocrine tumor study group, we learned that patients that have a grade 2 and grade 3 well-differentiated neuroendocrine tumors are at higher risk for recurrence, particularly in the first 3 years post-surgical resection. We also know that patients that have metastatic disease but are able to be resected at the time of resection of the pancreatic neuroendocrine tumor are also at much higher risk of recurrence. So these are our main criteria for definition of high risk for recurrence in the well-differentiated grade 2 and grade 3 pancreatic tumors. And for the grade 3s, they have to have a Ki-67 less than 55%. So then patients who identify will be randomized in a 2-to-1 fashion to 4 months of Capecitabine and Telozumab versus observation. The patients will be stratified by grade and stage. Our primary endpoint is 3 years recurrence-free survival. And we'll have several correlative studies that are in development. We're also going to look at the NET test as a marker to assess recurrence. Patients will be followed initially with imaging every 6 months for the first 3 years, and then every 2 months for the subsequent years. I also want to emphasize to our colleagues that some of the visits, particularly in the observation arm, especially in the first 6 months of the trial, will be allowed to be as telemedicine to hopefully facilitate engagement and participation of our patients. And we hope to enroll 154 patients. And that's what I have. Again, I would like to really thank the SWOG team for this strong teamwork in getting this trial design and activated. Thank you.
Thank you, Heloisa, and thank you for your colleagues and the team who worked on. And I'm glad to see that on Twitter, you guys are already talking about it so that we can let everyone know that the study is open.
If I may also, there is work, the digital engagement has developed some social media toolkits that are already being used, and I think SWOG 2104 is next in line for development. So there is going to be a lot of social media support and materials to share with colleagues. Thank you, and patients.
Thank you very much. Thank you. I do not have any questions for you from the audience, so I think we can move on to the next study, which is the NRG GI004 SWOG S1610, and Dr. Overman will be presenting. Dr. Overman?
Thanks, Philip. Yeah, this is a study that that's gone through numbers of iterations. And so currently it's really looking at frontline deficient mismatch repair metastatic colorectal and looking at atezolizumab monotherapy. So kind of your PD-1, PD-L1 question versus combination chemotherapy and PD-L1. And so this is in collaboration with NRG, led by Kaio at Roche Lima. The next slide. We go through go through all the kind of the edits there. So initially the study started a while ago, and due to the Keynote 177, I think we would say standard has really become kind of PD-1 monotherapy, and I think it works very well. I think the challenge is that it does have a limitation in how well it works. And so I think I would kind of be here to make the statement that we do believe that the idea of combination chemo with PD-L1 is still a very, very valid question to ask, because we do want to kind of move up the benefit for these patients. And the design to 2 arms has also helped in regards to kind of enrollment numbers. So it's kind of declined it down to 211, and then kind of open enrollment to kind of any MSI high or deficient mismatch repair identified patient. Next slide. And so here is the Keynote 177. And as you can see, at 12 months, 45% of patients have progressed, right? So about half of patients are progressing. So clearly an improvement over what we would say would be chemotherapy, but I think we would ask if we can do better. And I think in other tumor types, we've clearly seen chemotherapy and immune therapy having synergistic benefits. And so that's kind of one clear cross tumor type space that we've seen. And then there's also a lot of kind of preclinical data that suggests, there could be benefit with VEGF targeting and chemotherapy, in particular oxaliplatin. And so that would enable both that kind of tail the curve to be raised and also address that kind of early progression fraction, which we see as well in patients. So next slide. And so this is some of those preclinical data that exist that's pretty clear out there in regards to kind of VEGF and oxaliplatin. And so we can go to the next slide. That's nice to see. But I think there was a real recent data set that I think is really interesting and kind of further lends support to this. So this was presented at ESMO. This is a Tezo tribe, unselected population looking at FOLFOXIRI versus FOLFOXIRI-Bev versus FOLFOXIRI-Bev Atezo. And it was a positive study overall. And then deficient mismatch repair population was really dramatically positive. So you can see there in a total of 13 patients, it had a p-value of 0.002. And that's really because the combination chemotherapy and Atezo arm just did fantastic, right? So there really is an open question that, yes, PD-1 therapy, monotherapy does well, but can we do better? And I think the very simple question, and I think the data seems to suggest that that's very possible, that we can actually really do a lot better if we consider combination chemo and kind of immune therapy, as we see in other tumor types, right? So next slide. And so that leaves us with kind of what we currently have. So here is the study. Again, we have 74 of 211 enrolled. We had 3 recent enrollments actually. And so please, consider it. I think it's relevant. Clearly, we are testing these patients more and finding them up front. And really now it's both arms are getting immune therapy. And I think the addition of chemotherapy is a fairly, standard understanding. So thank you all.
Thank you, Michael. Why do you think it's slow to accrue? Are people treating patients off protocol, or what's going on?
Yeah, I mean, I think, one, so knowing your molecular status up front when you start, right? I think that's one, we've kind of heard that common kind of, phenomenon across the board. I do think with IHC, really, we should be getting that pretty quickly, so I think there is a path to kind of address that one. I think, you can definitely give this off label. I think giving, pembrolizumab, nivolumab are pretty straightforward, and we do that a lot. And I understand that. And I think, PD-1 works a lot better than chemo, right? I mean, there's no doubt about it. Keynote 177 was really nicely positive. I think the issue I would say is that our goal for deficient mismatch repair MSI high tumors should really be like getting it up to, 100% cure rate, right? Like, I mean, these tumors, we can do better. I think there's no doubt about that. And so I do really think the prelim data from the Tezo tribe and other tumor types, the idea of combination chemo with a VEGF targeting agent and PD-1, PD-L1 has a real rationale and a real kind of potential expectation to improve and do better on already, doing well, right? So I think partly that's kind of the perspective, but I'd really kind of encourage us to say, let's kind of do even better than what we've done, right? Doubling down and do even better than what monotherapy's done for us. And I think this study does lay us a path to do that, and a pretty straightforward path to do that.
Yeah. Okay, thank you. I do not see any questions. Thank you, Michael, again. And we move on now to the subcommittees, and we start off with the Esophageal Gastric Subcommittee, Drs. Iqbal and Weinberg.
Hi, this is Saima Iqbal. I'm presenting for Zeb Weinberg and myself. Next slide, please. So as you know, there's been a lot of changes over the last year or so in upper GI cancers, and I'll just review some of the newest ones. We'll go over the 4 active Nctn studies, or 3 active and 1 nearly active, and then we have 2 SWOG concepts that are in development that I'll review with you as well. Next slide, please. So just as a quick review, I think the upper GI space has really been rattled the last year in a good way. We've had several changes in our standard of care, where immunotherapy in the metastatic disease setting has been moved to the front line. We have immunotherapy incorporated into adjuvant care in esophageal and gastroesophageal disease. And we have new agents that have demonstrated activity in the HER2 positive setting. Next slide, please. So at ESMO this past, just a few weeks ago, I guess, there was an update on Checkmate 649. We saw the data last year for chemotherapy versus chemotherapy plus nivolumab, which led to the approval of nivolumab in the frontline setting. We hadn't seen the Ipi-Nivo combination data versus chemotherapy. As you may recall, this arm of the study was halted early at DSMC recommendation. So this data was presented. Next slide, please. The overall survival data, as you're aware, for nivolumab plus chemotherapy versus chemotherapy for the CPS 5 or greater, for the combination was 14.4 months. For the chemotherapy alone was 11.1 months. Next slide, please. And then for the combination of nivolumab plus ipilimumab, you see 11.2 months in overall survival and 11.6 months for the chemotherapy for the CPS 5 or greater. So the preset secondary endpoints weren't met. Next slide, please. In terms of practice-changing studies, Keynote 811 was presented by Dr. Jen Jigian at ASCO this past year, which led to the approval of immunotherapy in combination with chemotherapy plus trastuzumab. Next slide, please. So as you're aware, the standard of care for HER2 positive patients is chemotherapy, usually fluoropyrimidine platinum plus trastuzumab in the frontline setting. There have been phase 2 studies which have shown really promising response rates with the addition of immunotherapy. So this was a randomized phase 3 trial done globally for untreated patients who received standard of care chemotherapy with fluoropyrimidine, platinum, and trastuzumab versus chemotherapy, trastuzumab with pembrolizumab. The primary endpoints were overall survival and progression-free survival, secondary endpoints of response and duration of response. Next slide. So as you see, the response rates held up in this phase 3, with the Pembro arm revealing a response rate of 74.4%, with the chemotherapy trastuzumab at 51.9%, the CR rate actually at 11% for the Pembro arm. Next slide, please. So essentially, this was a clinically meaningful improvement in the overall response rate of nearly 23% with the addition of IO to chemotherapy plus trastuzumab. The responses that were seen were deeper and more durable. There were no new toxicities noted, and we'll get the data soon. So given this, next slide. The FDA approved pembrolizumab in combination with chemotherapy and trastuzumab. Next slide, please. So in terms of ongoing studies or other pathways that are being investigated by industry for the most part, I think this changing landscape actually has hurt a lot of the ongoing trials. These studies are still open. There's still promising pathways that are being looked at, but I think across the board, we're seeing that there's been some difficulty in accrual to these studies, and it's really changed some of the designs that and some of the proposals that we had in the pipeline. So we've had to take a step back and kind of relook at things. Next slide, please. So in terms of the ongoing studies that are open through Nctn, we have EA2174, which is a phase 2/3 study of perioperative nivolumab and ipilimumab in patients with local regional esophageal and gastroesophageal junction adenocarcinoma. Jennifer Eads is the PI of this study. Our SWOG champion is Dr. Caitlin Kelly. This trial is a randomization to carboplatin paclitaxel radiation set across standard of care versus cross plus nivolumab. Patients are then undergo surgery. And then there's a second randomization to nivolumab alone for 6 months versus nivolumab plus ipilimumab. The accrual for this study is 278. And of those, I think there are 91 currently on trial. Next slide. EA2183 is a phase 3 study of consolidated radiotherapy in patients with oligometastatic HER2-negative esophageal gastric cancer. So these are untreated patients with metastatic disease who have 3 or less sites of metastases. These patients receive induction chemotherapy with FOLFOX or CAPOX for 4 months. And if they have no evidence of progression, they're randomized in a 2-to-1 fashion to consolidative radiation therapy to the oligometastatic sites. And then a continuation of chemotherapy versus a continuation of chemotherapy or systemic therapy alone. The study's accrued 14 patients and is now on hold as it's amended to include immunotherapy with the change in the standard of care approach. So we anticipate it'll be open soon. I should mention Paul Oberstein is the SWOG champion for this trial. Next slide, please. The NRG GI006 is a phase 3 randomized trial of proton beam therapy versus Imrt for localized esophageal cancer. So essentially this trial is the cross regimen chemotherapy with carboplatin paclitaxel with the comparison of the photon beam therapy versus the IMRT. I believe 72 patients have been accrued to this trial for a total of 300 are proposed. Steve Lynn is the PI and Dr. David Jen is our SWOG champion for this trial. Next slide, please. And then lastly, this trial just went through the GI steering committee and was approved. And so we should have a full protocol soon. This is Dr. Park's trial from the Alliance. This is a randomized phase 3 trial of modified FOLFIRINOX versus FOLFOX with nivolumab for the first-line treatment of metastatic HER2-negative gastroesophageal adenocarcinoma. So these are untreated patients with esophageal gastric cancer who are randomized 1-to-1 to the triplet regimen plus Nivo versus standard FOLFOX plus Nivo. And the primary endpoint of the study is survival, and they're looking to accrue 382 patients to see an improvement of from 13 to 19.1 months, hazard ratio of 0.68. So this should be opening very soon. Next slide, please. Moving on to the two SWOG proposals. The first is Dr. Anwar Said's study, and this study has taken multiple iterations, so kudos to Dr. Said. This is a phase 2/3 trial of switch maintenance with nivolumab plus Cavazatman versus the continuation of first-line nivolumab plus chemotherapy in esophageal gastric cancer. These are untreated HER2-negative patients who will receive induction chemotherapy with 5-FU oxaliplatin-based regimen plus nivolumab, and should have a CPS score of 5 or greater. These patients will be randomized to nivolumab with Cavazatman versus a continuation of nivolumab with chemotherapy. The primary endpoint of this proposed phase 2/3 will be progression-free survival for the phase 2 portion, and then overall survival for the phase 3 portion. Next slide, please. The statistics are being designed and confirmed, but preliminarily we have some numbers that Dr. Said has proposed in that for the phase 2 portion, we're looking at about 80 patients to look at an improvement in PFS from looks like 3.5 to about 6+ months. And then those patients will be included in the phase 3 sample where they're looking to enroll 240 patients. But these stats are preliminary and are looking, as the study's finalized, will be reassessed. Our second proposal is by Dr. Joseph Chow. This is a randomized phase 2/3 trial of perioperative SWOT alone or with trastuzumab and atezolizumab in resectable HER2 positive GEJ or gastric adenocarcinoma. These are resectable patients who will be randomized to the standard of care of FLOT for 4 cycles in the perioperative setting versus FLOT plus trastuzumab plus atezolizumab perioperatively. These will be patients who are CWRTS 3 for the GEJ or gastric cancer patients, HER2 positive by standard criteria. And this is also proposed as a phase 2 lead-in and then phase 3. The primary endpoint of the phase 2 will be pathologic complete response. And then for the phase 3, he's proposed progression-free survival as the endpoint. Next slide, please. This study is also being developed, and so the statistics are rough here. We're anticipating that the phase 2 portion will accrue, the total accrual, we're looking at less than 100 patients. And then for the phase 3 PFS endpoint, the hazard ratio at 1.6, the projected preliminary numbers look at about 242 patients to complete this study. Next slide. So in terms of future developments in the perioperative setting, there's currently an alliance proposal looking at total neoadjuvant therapy and ctDNA. This was a proposal that there have been several proposals in this area, but that's being assessed currently. We are exploring concepts in the second-line setting, looking at immunotherapy beyond progression. We're open to looking at incorporation of novel agents, both in the second line and beyond, as well as the refractory setting. So with that, I'm happy to take any questions, or we can move on. Thanks so much.
Thank you very much, Saima, for this great presentation summarizing the latest in the field and Nctn, and also what the future will be looking like. Thank you very much. I would like to take this opportunity also to encourage people, especially younger faculty and younger clinicians who would like to come up with some ideas to discuss those with the subcommittee chairs. So for the upper GI, obviously SIMA and ZEV, but as we go along, we have 6 different subcommittees, so please feel free to communicate with them, with the leaders. No other questions, so we go ahead now. We go forward to the next slide. Next. We had congratulated Dr. Kurian for being the vice chair of the committee. She was the co-chair of the subcommittee of the pancreatic, so now we have Dr. Sohal, who's working with Dr. Lawi as co-chairs. Go ahead, please. I don't know, Andrew, are you going to present or?
I think Devendra was going to present.
Okay, go ahead.
Okay. Thank you.
I think the audio might be a bit problematic.
Next slide.
Okay.
So the ECOG study of randomized phase 2 is on gemcitabine nab-paclitaxel compared with 5-fluorouracil nanoliposomal irinotecan in older patients. They are defined for this study as age greater than 70 or greater. So they will be randomized in a 1-to-1 fashion to gem nab-paclitaxel versus the Napoli study regimen. And the primary endpoint for this is progression-free survival. The study opened June 2020 and has accrued 57 patients out of 184. The stratification is age 70 to 74 versus age 75 or greater, and SWOG champion is Dr. David Zen at University of Washington, Seattle. Next, please. The Alliance trial of perioperative versus adjuvant therapy is ongoing. This is for resectable pancreatic cancer. Lead study chair is Dr. Cristina Ferroni. In this study, the approach being tested is the textbook standard of surgery followed by all adjuvant FOLFIRINOX based on the PRODIGE study versus perioperative FOLFIRINOX, which is 8 cycles pre-op and 4 cycles post-op, essentially 4 months pre-op, 2 months post-op around surgery. The stratification is by location of tumor and ECOG performance status 0 versus 1. Dr. Stephen Berman at the University of Tennessee is the SWOG champion. The study opened middle of 2020 and has accrued 66 patients out of 350 so far. So about 1/5 done. Next, please. The ECOG study of olaparib MINT versus placebo following adjuvant therapy is ongoing. This is for resected pancreatic cancer, testing a PARP inhibitor maintenance approach. The tumors have to have a pathogenic BRCA1, 2, or PALB2 mutation. Please note this could be germline, so the patient could have the mutation, or the tumor could be somatic. The tumor could have the mutation. Patients receive adjuvant therapy, and after that, they are randomized to olaparib versus placebo, and relapse-free survival or recurrence-free survival is the primary endpoint. Obviously, patients get surgery first and then adjuvant therapy, and are pre-registered after the surgery. It was activated.
I think, sorry, there's some background noise. If you're not speaking, can you please mute? Okay.
The accrual, the study was activated in April 2021. The accrual is only 9 patients so far, obviously early days.
Okay.
Next slide, please. This proposal is by Dr. Gregory Bora at University California, San Diego. This proposal is a phase 2/3 study of Gemnab-paclitaxel plus minus CEND1 for first-line treatment of metastatic pancreatic cancer. This is a nice approach of using a small peptide that essentially works on the stroma of the tumor and allows better influx of chemotherapy. The phase 2 portion uses progression-free survival as the endpoint, and if that is met, the phase 3 portion will use survival.
Sorry, we lost you.
Can you hear me?
Now we can.
Okay, sorry. Maybe my connection is a little soft. Next slide, please. This is the future plan for 1505. Dr. Sai Ahmad and myself are working on this. This is an approach to test total neoadjuvant therapy in pancreatic cancer based on results of 1505. This is also a rolling platform with a phase 2/3 design. The approach is to use FOLFIRINOX as the control arm and then add novel agents in a rolling platform fashion where they can be added one at a time. The phase 2 endpoint will be time to treatment failure. The phase 3 endpoint will be overall survival. Arms succeeding in the phase 2 assessment will obviously roll over into a phase 3 assessment. Next slide, please. One back, please. We have some candidate drugs as novel therapies. Some stage 4 data are pending, and then we will be adding them in this neoadjuvant platform. I'm happy to take any questions. Thank you.
Thank you. Thank you, Dr. Sohal. In terms of the EA 2192, it's accruing well, 9 out of 152 patients, whereas Vincent Chung's trial is not accruing well. How do you see that discrepancy? They are both for the BRCA germline.
I think the ECOG study also allows somatic mutations, so which are quite, not quite, but still more common than germline alone, whereas our SWOG study by Dr. Chung is only germline, which is perhaps 5% of cases.
Okay.
That may be a difference. And also in terms of the opening of the sites as well, because Kim Reese is actually interested in being champion for the study with an ECOG. So I think once again, academic sites open up, accrual will pick up.
Okay, I was just wondering. Yeah. Okay, thank you very much. Any questions? If not, then we go to the next subcommittee, which is the hepatobiliary.
Yes, hi, this is Anthony Al-Kuwairi. I'm presenting on behalf of my co-chairs, Rashna Ashraf and Sai Ahmed. And if you go to the next slide, please. So we're starting with biliary cancers. We'll briefly review the standard of care and talk about what we're doing in this disease. Next slide. So the current standard continues to be the combination of gemcitabine cisplatin for patients with advanced biliary cancers, meaning unresectable, locally advanced or metastatic. This is based on the ABC-02 trial that has shown a survival benefit with this combination compared to gemcitabine alone. Next slide. This is the improvement in survival. Again, modest still with a median OS of almost 12 months with the combo versus 8 months with gemcitabine alone. Next slide. Now, an attempt to beat gemcitabine cisplatin in Europe with FOLFIRINOX. And this started as a randomized phase 2 study to potentially go to phase 3. And basically, this was rather negative, and it will not move to phase 3. And so GemCis continues to be the current standard of care. Next slide. This is the GAP study, which stands for gemcitabine, Abraxane, or nab-paclitaxel, and cisplatin. So it's a triplet that Dr. Schroff did. This was a study done at MD Anderson and Mayo, Arizona. 60 patients with advanced biliary cancers. The one thing to highlight in this study is that the dose of gemcitabine as well as the dose of nab-paclitaxel had to be reduced because of cytopenias. Next slide. And this has been reported in JAMA Oncology, and you can see here that there's a very intriguing median PFS of 12 months, which looks as good as the median OS that we had seen with GemCis, and a median OS of 19 months, a response rate of 45% in the 50 evaluable patients, including some patients that downsstaged and underwent resection. So it's a promising regimen. Next slide. And this served as the impetus for our SWOG 1815, which is the randomized phase 3 study of the triplet versus gemcitabine, the current standard. This was a 2-to-1 randomization. We have successfully completed the accrual to this study with more than 400 patients recruited. And we continue to look forward to the results. This is actually the only randomized phase 3 study in biliary cancers to be conducted in the United States, outside of some industry trials in which we are participating. So it's a major accomplishment for SWOG and the Nctn in general. And this accrued at a very rapid pace. Next slide. Now, what about second line? Next slide, please. So we need to do much better in second line. Our current standard continues to be FOLFOX based on this ABC06 trial, which took patients who had failed first-line treatment, gemcitabine-based therapy, and were randomized to FOLFOX or best supportive care. And next slide. Next slide, please. And here you see the modest improvement with FOLFOX versus best supportive care, with a median OS of 6.2 months versus 5.3 months. And it has a ratio of 0.69. So certainly there's a small subset of patients that derive temporary benefit from this combination, but it's an area that definitely warrants much more research and improvement. Next slide. So some of the major advances in biliary cancers now have happened in the molecular subsets in this disease. And this is a heterogeneous disease, biologically distinct based on location, whether it's gallbladder versus extrahepatic versus intrahepatic cholangiocarcinoma. For today's discussion, I'll draw your attention to the fact that intrahepatic cholangiocarcinoma tends to harbor FGFR alterations, mostly FGFR2 fusions and IDH mutations. And then we do see RAF alterations both in across the locations, but more commonly in extrahepatic. And there's been some great progress there. Next slide. Sorry about this animation. I should have removed it. Next slide. Okay, so this is the most recent data released for Clarity, which is the study that evaluated ivosidenib, the IDH inhibitor, versus placebo in second or third line biliary cancers post-GemCis. Patients must have had an IDH1 mutation, and this was the primary endpoint of PFS. So this, you see the hazard ratio of 0.37, so a 63% improvement in progression-free survival or reduction in the risk of progression, and a great disease control rate, 53% versus 28%. Of course, the medians don't look great, but you can see from the curves that there is a subset of patients who have significant improvement in progression-free survival. Next slide. The OS was a secondary endpoint, and of note, this study did allow crossover, and more than 50% of the patients crossed over. So the OS signal is diluted, but nonetheless, you see 10 months with ivosidenib, 7.5 months with placebo. And when this is adjusted for second-line therapy and for crossover, The median OS for placebo goes down to 5 months, and the hazard ratio now becomes 0.49. Based on this, the FDA did approve ivosidenib for IDH-mutated cholangiocarcinoma. Next slide. FGFR2 fusions is another area of very active investigation. Multiple compounds are being evaluated. I show some of the results here. Up to this point, this has been mostly phase 2 data, but that's resulted in the accelerated approval of both pemigatinib and infigratinib up to date. And these agents now are being evaluated in first-line therapy with chemotherapy, and in some other potential smaller settings that we'll get back to. Next slide. And lastly, this is the RAF V600E mutation in cholangiocarcinoma. This was a subgroup or a cohort of the ROAR study where the combination of dabrafenib and trametinib showed a very promising response rate, as you see here in the waterfall plot. And this is being taken forward in different settings as well. Next slide. So as far as the Nctn, this is an alliance study, but Dr. Schroff, my co-chair, has contributed significantly to the development of this trial that's moving forward. And this is taking patients with alterations in the MAP kinase pathway, which can be up to 40% in some, in at least extrahepatic cholangio, maybe 20% or so or less in intrahepatic. And these patients will be randomized in second line to FOLFOX, the standard of care, versus FOLFOX with binimetinib, which has been evaluated as a single agent and there's a small but promising signal. This is the MAC inhibitor. Primary endpoint will be overall survival with a target accrual of 65 patients. So great trial, and encourage you to support it. Next study. Next slide, please. Next one is on to early stage disease with gallbladder cancer. This is a study, it's really a surgical trial to look at the optimal perioperative therapy for incidental gallbladder cancer. This is an entity that we tend to see quite a bit of patients who underwent a lap cholecystectomy, thinking they have cholecystitis and incidentally are found to have cancer. And they usually have to go back and undergo an oncologic resection. Next slide. So in this study, before going back to undergo an oncologic resection, they would be enrolled into the study and randomized to either surgery upfront versus neoadjuvant chemotherapy with the current standard, with is gemcitabine cisplatin. And then after that, if they have no progression, they would undergo resection as well. And then post-resection, everybody gets more gemcitabine cisplatin. Even though this is not the current adjuvant standard, this was the compromise design for this trial. It's accruing slowly, but an important question, and please consider opening it at your site if you see these patients. Next slide, please. Our areas of focus for development in biliary cancers now are, we are continuing to explore concepts, and we have one that's in evolution, looking at perioperative setting and incorporation of some of the targeted therapies for FGFR and IDH and other. This will be a pan-Nctn effort as well. We would like to build on our success in first-line treatment with the triplet of gemcitabine, Abraxane, cisplatin. So we would love to contemplate more concepts in that space. And of course, there's plenty of room in second line, especially for all comers who don't have specific molecular alterations. Next. For hepatocellular carcinoma, next slide. The current standard is atezobev, as everybody knows, with a median OS of 19 months compared to 13 months with sorafenib. Next slide. And this space continues to evolve. We heard today through a press release that the Himalaya trial with the combination of PD-1, CTLA-4, durva-tremi is positive. We will hear more, likely at ASCO GI, I would assume, about this combination. So we're going to have more than one combination as first-line options in this disease. And there are many other studies exploring other combinations as well. In second line, post-immunotherapy, there is no current standard at all. we are using multiple TKIs and sequencing them without any specific data. Next slide. In the Nctn, the NRG-GI003 study continues to recruit steadily but slowly. And this is a study looking at patients with mostly liver-limited disease and who are randomized to photon versus proton therapy. It's at the total accrual of 57 currently. Next slide. Here are the eligibility criteria, which I will not go into, but it does allow some degree of portal vein tumor thrombus as well. Next slide. This is RTOG 1112, which has been completed, and it's actually closed, but didn't really reach its target accrual. The accrual was trimmed down, but we look forward to the results of this study, hopefully, to better establish the role of SBRT in this disease. Next. We have the two concepts in development in SWOG, one that's neoadjuvant of Nivo-Ipi in patients with resectable HCC, and one that's looking at Durva-Tremi in patients with Child-Pugh-B liver cirrhosis. Next slide. I'll briefly review these, and that will end my presentation. So please go ahead and hit this to complete the slide. Advance. So this is the design of this neoadjuvant trial. We are going to take patients who are resectable. We will have a run-in phase to kind of reconfirm the signal seen in the MD Anderson trial that Dr. Kasab has performed. So at the end of the run-in with 30 patients, we will look at the probability of failure to reach resection and make sure that doesn't exceed 20%. And that the observed pathologic response rate is 15% or higher. If we meet these thresholds, this will go to a randomized phase 2 design where 50% of the patients will have neoadjuvant Nivo-Ipi, followed by surgical resection versus upfront surgical resection. The primary endpoint will be median recurrence-free survival, and we will need about 88 patients per arm. Of note that with Nivo-Ipi in the MD Anderson trial by Dr. Kasab, the pathologic response rate was between 25 and 30%, including the major pathologic response, not only the complete pathologic response. So very promising approach that's evolving in many tumor types, and we're excited to move this forward in HCC, and this concept will be going to CTEP and the steering committee for review. Next slide. This is more details for the experimental arm. They will get Nivo-Ipi. The Ipi will be at 1 milligram per kilogram, 2 doses only, and Nivo every 2 weeks for 6 doses. Surgery will be between weeks 12 and 14. Next. And then the last concept by Dr. Sukeshi Arora from San Antonio. Very important question, unmet need area for patients with advanced HCC and Child-Pugh-B cirrhosis. We know that there's some data for Nivolumab in this space, if you go to the next slide. So we have data for Nivolumab from Checkmate 040 with a response rate of 10 to 12% and an OS of 7 months. And we have some data for Sorafenib in Child-Pugh-B cirrhosis as well. But we really don't have great active agents in this space. Next slide. So the design here is to take the Durva-Tremi combination known as T300 plus D. The reason it's known as that because it gives one loading dose of Tremi up front and then continues with Durvalumab alone based on study 22. And this has been shown to be active in Child-Pugh-A with a promising response rate of over 20%, median OS of 18 months. These are actually mostly second-line patients. And we just heard today that Durva-Tremi is positive in Himalaya in first line. So great reason to move this combination and evaluate it in Child-Pugh-B disease. Next slide. So this will be the design. We will do a safety run-in of 10 patients. And if we do not cross the safety threshold, this will go into an expansion with an additional 49 patients. And with 59 patients, we will have 90% power to look at our target response rate of 25% versus a control of 10% historically with Nivolumab. Next slide. These are the inclusion criteria, which largely mirror the inclusion criteria from Checkmate 040, so we can do a fair comparison historically. This will be limited to Child-Pugh 7 and 8. Next slide. I think this ends my presentation.
Wow, that was very good. Thank you very much. Excellent. Well, fantastic. Thank you. A couple of questions. Dr. O'Rourke is asking a question about 1815. CT scan image files, are they available to undertake a secondary analysis? And is specifically interested in sarcopenia as a prognostic marker in patients who were treated.
Yes, I agree. Sarcopenia is an important question in this disease, similar to pancreas. I do not believe the study has central radiology because the endpoint was OS. So we did not do this. Question whether we could go back and do it in a subset of patients retrospectively, that would have to be contemplated.
And another comment he makes, Child-Pugh HCC is a huge unmet need. I think all of us agree with that. Would you not?
Oh, absolutely, absolutely. And the question is, selecting the right Child-Pugh patients who should be treated. And we continue to suffer from no randomized studies in that setting. Like, is it worthwhile treating the cancer in Child-Pugh? We don't know. So patient selection continues to be very important. That's why we focused on this space. So we're glad that others believe it is a priority and an unmet need as well.
And Anthony, you made a very interesting comment earlier today in the other meeting that with Tremi and Durva, you're not concerned obviously about bleeding esophageal varices, and so that's an important point, correct?
I mean, absolutely. I would say I am less concerned with Durva-Tremi compared to Atezo-Bev, especially in patients who have more advanced liver disease, and more portal hypertension. So it really expands our options in this space.
Yeah.
Anthony, I have a question. So really the question of Atezo-Bev versus Durva-Tremi is very important, and also the sequencing. I remember Dr. King has proposed the second-line Durva-Tremi in HCC a while ago, and there was a concern about, the AstraZeneca may not be interested because of their upcoming data. So do you think there is interest in a sequencing study or a head-by-head, starting with one first, the other one second, and the other way around? Or you think that really there will be now not a battle, a friendly battle for the first-line space?
Yeah, look, comparing a PD-1 CTLA-4 versus PD-1 with a VEGF inhibitor in first line, I honestly don't think any company will do it, whether we take this on in the Nctn and whether we consider that a priority versus building on these doublets in first line. As you know, there's going to be some triplets being evaluated now. I think the more important question, Gabby, and I agree with you, is the sequencing question and really looking at what has good activity in second line and how should we sequence the agents. And I think regrouping in SWOG and other Nctn groups about developing such concepts will be very important. So I agree with you as a short answer, but I don't think a head-to-head will happen, in my opinion.
Anthony, an educational question, at least for me. The FGFR story.
Yes.
So we do a lot of this NGS and we get FGFR mutations or amplifications. And as you know, the drugs were approved for fusions. Can you comment on what do we do with patients who have either mutations or amplifications?
Yeah, so look, the data for mutations so far is not great. I mean, there's some activity with these agents, but it's a lot less than what's seen with fusions. But however, there are second-line FGFR inhibitors now that are more selective or more active, and those will be evaluated or are being evaluated in patients who have mutations. So hopefully there'll be more trials to look at that. Amplifications are actually quite rare in cholangio, but these anecdotally tend to respond to the current FGFR2 inhibitors that we have.
Yeah. Okay. Thank you very much. And no other questions, so we can move forward now to the colon subcommittee, and we have Dr. Wells Messersmith and Dr. Phil Gold.
Good afternoon, everybody. I'm going to present these slides on behalf of my co-chair, Dr. Messersmith, who couldn't be with us today due to a competing grant meeting. Let's go to the next slide, please. Before we get started, I would just like to mention that Dr. Messersmith is going to be stepping down from his role as co-chair of the SWOG colon subcommittee. He's been an incredible leader for a number of years, and wish him the best in his new endeavors in his new position in Colorado. That being said, we are going to be soliciting applications for folks that may want to step up to this position, and there'll be more details to follow about how that mechanism is going to work. We're going to start out with active studies. Next slide, please. SWOG 1613. Dr. Raghav is the PI. This is our randomized phase 2 study of trastuzumab and pertuzumab versus cetuximab and irinotecan in metastatic colon cancer with HER2 amplification. This trial has been very slow to accrue for a number of reasons. One of the first major reasons is the fact that the lab that does the required IHC testing for HER2 has moved no less than 3 times and has resulted in many prolonged breaks for enrollment. On top of that, we're looking at a mutation here that's present in the HER2 positivity rate of about 4 to 5%. So the trial has accrued, but the sample size has recently been reduced to 62 patients. Next slide, please. As of now, there have been just over 50 patients accrued, and it's at about 81% of accrual. The study will be closing right around year's end. So I would encourage everyone to review and see if they have any potential eligible patients. So not only the lab issue, but also the fact that we're dealing with a study with a very, very low rate of positivity with regards to the HER2 amplification are probably the 2 major reasons this has been a bit slow to accrue. My hope is we will still get some useful information out of the study once it does finally close. Next slide, please. SWOG 1922, Dr. Overman is the PI. This is a randomized phase 2 study of ramucirumab and paclitaxel versus FOLFIRI in the second-line management of small bowel adenocarcinoma. This trial activated in 2019, but the first patient did not enroll till July of 2000, and it's currently enrolled 17 patients. Can we go to the next slide, please? Here you can see the randomization to ramucirumab and paclitaxel, standard dose and schedule versus FOLFIRI. Please note that the ramucirumab is provided in this trial. So once again, slowly accruing study, but it has picked up a bit in the last few months, and a disease that's not all that common. So once again, please try to enroll patients on this. We're looking to get 94 patients. Let's move on to the next study, please. SWOG 0820, this is Dr. Zell's study as the PI, a double-blind, placebo-controlled trial of fluornithine and Solandac to prevent recurrence of high-risk adenomas and secondary colon cancers in patients with colorectal cancer. Let's move on to the next slide, please. So this trial has been open for quite some time. It was modified from a 4-arm study to a 2-arm study, so now patients are randomized between eflornithine and Solandac or to placebos. Accrual is at 320. The accrual has slowed down a bit in the recent months, and there are plans to talk about the best way moving forward to move forward with this trial. Once again, would encourage everybody to participate as it's getting closer to getting completed, but there are concerns about its current accrual rate. Let's go on to the next slide, please. 1610 would also be on this, but Dr. Overman already gave his presentation, so we'll move to our active Nctn studies. Let's go to the next slide, please. The atomic study, Dr. Liu from Colorado is the SWOG PI. This is a randomized trial in patients with deficient mismatch repair and stage 3 colon cancer who are randomly assigned to either FOLFOX and atezolizumab, then further maintenance atezolizumab versus standard of care FOLFOX. The trial is accruing well at 14 per month, 484 out of the 700, and 51 accruals have been attributed to SWOG. So once again, for your patients with mismatch repair deficiency, please enroll them in this study. Let's move on to the next slide, please. NRG-I005, phase 2/3 study of circulating tumor DNA as a predictive biomarker in adjuvant chemotherapy for patients with stage 2A colon cancer. Dr. Morris of Anderson is the overall PI, and our SWOG champion is Dr. Scott. The study activated also late in 2019 and has accrued 187 patients. Only 7 of those are from SWOG, so we really have to take a good look at the study and start trying to get patients on. Basically, you're going to have your patients who have stage 2 disease, who you are planning for active surveillance. And then they'll be randomized to either arm 1, standard of care active surveillance, and in those patients, they'll have sampling and batch analysis of their circulating tumor DNA. Arm 2 is assay-directed therapy, in which there'll be a prospective analysis of their circulating tumor DNA that will guide decisions. If circulating tumor DNA is not detected, they will go onto active surveillance. If it is detected, then it will be investigator's choice of FOLFOX or CAPOX. Next slide, please. The next study is the Solaris trial. Dr. Kimi Eng at the Farber is the overall chair, and our SWOG leader is Stacy Cohn from University of Washington, Fred Hutch. A randomized, double-blind, phase 3 trial of vitamin D supplementation in patients with previously untreated metastatic colon cancer. Next slide, please. This trial is halfway accrued. It randomizes patients to basically FOLFOX or FOLFIRI, investigator's choice, as you would do, and then assignment of different vitamin D doses. The trial is a bit slow to accrue. It's a very easy trial to enroll to, so I'd encourage folks to participate. We really want to get it done as it's going to the halfway point. Next slide, please. We're now going to review some concepts in development briefly. Let's go to the next slide. The colon subcommittee has really been quite active over the last year and a half. It's really been a pleasure to work with all the investigators as they work on their concepts. We actually have 7. We're briefly going to discuss them, and you'll hear more about them as time goes on. The first one, Dr. Gulami has a platform to study immune-augmenting treatment strategies for microsatellite stable colon cancer liver metastasis. This looks like a trial of neoadjuvant Lenvima and Pembro. That's going to be done initially as a small study at her home institution at Davis, and then we'll see about employing it within the group. The next study to discuss, you've already heard about Dr. Morris, the phase 2 trial of encorafenib and cetuximab with or without nivolumab for patients with microsatellite stable BRAF V600E metastatic colon cancer. And as previously mentioned, we hope this to be activated in the coming months. In cooperation with our surgical colleagues, Drs. Patel and Dineen have created a cytoreductive surgery HIPEC study for high-grade appendiceal cancers, in which patients will have a run-in of chemotherapy, laparoscopy, and then debulking in HIPEC. This is going to be a limited institution trial open at several centers to see if we can do a cooperative group study within SWOG for this very important unmet need. So you'll be hearing more about this study. Next, Drs. Krishnamurthy and Senthil are working on a concept of a phase 2 randomized trial of perioperative chemotherapy with or without immunotherapy for colon cancer, and that will include patients with bulkier tumors you would consider neoadjuvant therapy for. Next, the Circulate study, which is a stage 3 trial looking at circulating tumor DNA, run with in partnership with Dr. Desari of NRG, and Dr. Liu is the SWOG champion, and we will look at a slide since that is about to open in a few months. Recently, Dr. Faki from City of Hope presented a phase 2 trial of regorafenib, ipilimumab, and nivolumab versus regorafenib and nivolumab in microsatellite stable chemotherapy-resistant metastatic colon cancer. This is a very interesting concept. It focuses on patients with lung metastasis. As many of you know from studies in Japan, there was initially great promise in the concept of combining regorafenib and nivolumab, but follow-up studies could not duplicate those results. However, there is compelling evidence to show that if you exclude patients with hepatic metastasis, there could be benefit if we focus on lung only. This was presented at the NCI Colon Task Force earlier this month and was favorably reviewed, and we're looking for a follow-up call to review a survey with the task force in the coming days. Finally, Dr. Saeed has a concept of a phase 2 randomized trial of Cavazatman and durvalumab for third-line treatments of patients with advanced colon cancer. And this trial would be open to all comers regardless of site of metastatic disease. This trial has a high level of interest and in the near future will be up for discussion at the colon task force. So as you can see, a large number of studies in development and some actually coming to fruition. Next slide, please. You've already heard about 2107, Dr. Morris's BRAF trial, so we can go on to the next slide. This is the Circulate trial, Dr. Liu and Dr. Desari. Patients with stage 3 colon cancer will get their circulating tumor DNA results within 6 weeks of surgery. If no circulating tumor DNA is detected, they'll be randomized to either CAPOX or FOLFOX at the investigator's choice versus surveillance with serial ctDNA. As long as no circulating tumor DNA is detected, they'll continue in surveillance. Should it become detected, they would cross over to the circulating tumor DNA detected arm, where patients are randomized to standard chemotherapy or intensified chemotherapy with FOLFOXIRI, and this trial should be opening early in 22. That is my last slide.
Oh, thank you, Phil. This was really very comprehensive. I do not see any questions in the chat. Do you want to make some additional comments? Do you have any? Because some of the studies, again, not only in the colon, we're not doing as well from recruiting patients from SWOG. Do you want to expand on that, or?
Well, you know, I think that is an issue. We tend to be more invested in our own studies. The vitamin D study in particular, folks have said, is just not that interesting. And that's been a challenge. Some of the other studies, you know, biomarker-driven studies are just tough to accrue to in the first place. I'd like to see more accrual to the COBRA study. Since most of us are not treating those stage 2 patients anyway, it really makes good sense to try to put them on that study, and I would encourage patients to enroll in that.
Okay. If I want to ask you another question, which is, what, give me a couple of studies, top studies, which were practice changing over you heard about over the last 6 months.
Well, there have not been a huge number of developments. We did learn about first-line BRAF therapy from ESMO, so that's going to be an exciting new option for patients. And of course, Enhertu was recently approved for HER2-positive colon patients, and that, of course, can create, you know, that could create some issues for the accrual we're having to 1613.
And the Pembro frontline in MSI high, that's maybe not so
well,
new.
Of course, that continues to do phenomenally well. Those patients are doing phenomenally well.
Okay, thank you very much, Phil. We go next to Lisa and Hagen, Rectal Anal Subcommittee.
Hi, I think Lisa's here twice, and I'm kind of using her link. So I think I'm going to start. Thanks for the opportunity. Next slide. So at the most recent, a lot of the updates in rectal cancer, most of us have come from ASCO most sessions were on advanced disease. So we're just going to focus on watch and wait. Next slide. And organ preservation. There was quite a bit of interest in organ preservation at the poster discussion sections at ASCO this year, and it continues to be something that patients are interested in. But there's a high level of variability in practice and how it's done. In 2021 at ASCO specifically, there was a couple of updates. The Imrt trial update looked at organ preservation by clinical response, and we were able to update and present for the first time our stage 1, early stage 2 NEO trial study, looking at organ preservation as the primary endpoint. Next slide. So the update from Oprah was looking at a secondary endpoint. As a quick reminder, the Oprah study was 325 patients treated with TNT with either an induction or a consolidation approach with chemo-RADs and chemotherapy. And this was an endpoint looking at organ preservation rates by a clinical response, which, as you know, is endoscopic and MRI-based after TNT. And there was quite a differentiation in terms of organ preservation rates by CCR, were 78% for complete clinical response. Near complete clinical response was pretty much tossed up 45%, and incomplete clinical response was 7%. So, this kind of data has been useful as we are looking at our post-treatment MRIs in tumor boards, as we do more and more now. Next slide. This is our data from the NEO trial, which is also an organ-sparing strategy, this time with stage 1 and very early stage 2 rectal cancer. The approach here was patients are treated with induction chemotherapy for 3 months and then have transanal endoscopic surgery. And then those with a good response are proceed to observation. The primary endpoint of the study was the pathologic downstaging, which was successful in 57%. And in terms of overall organ sparing, a total of 79% of patients had an organ sparing, successful organ sparing therapy with this approach. The follow-up was limited and we'll be seeing new data, but so far the local regional recurrence rate was 3.4%. Next slide. So some ongoing questions specifically about watch and wait and rectal cancer in general. What is the optimal watch and wait approach? Should we do chemo first or radiation first? How do we strategy? This might decline over time as there's more follow-up. In terms of, sorry, are you guys able to hear me?
Yeah, we can hear you now.
Okay, sorry. In terms of more prospective data, specifically for the watch and wait strategy, the Janus trial is pending. We'll touch on that in a moment. Number 2, what is the organ sparing strategy for stage 1 rectal cancer? And we have a NEO-RT study to update here briefly. We won't be talking about it too much as it's going through CCTG. And then finally, the big question is still out there, is trimodality therapy required for all stage 2, 3 rectal cancer? And that, of course, was a huge question for Prospect, which is awaited to report in 2022. Really, that study is the best rectal cancer trial of the century so far. So really important that we continue to see what happens with that study. And then again, asking the question, do all patients need TNT? Similar question, and we have a concept for that. So next slide. So we did have a retreat here. Rectal cancer is a very variable field. There's a lot of different practices and going in different directions. Prospects not even reported, and we're already moving into the TNT field. And so at the Rectal Anal Task Force, we had the question as to how do we define consensus for the design of future rectal cancer trials. So we did a retreat and we identified four working groups asking specifically how we should use short course radiation, the sequence of TNT, induction versus consolidation, chemotherapy, how do we better integrate patient preferences, what special subgroups of rectal cancer should we be looking at, and what are the rectal cancer specific study design questions that we should make sure we include. Next slide. And so the methodology was a Delphi methodology where we had sequential rounds of questions to identify consensus or lack thereof. We identified four groups. They came up with a list of questions. A survey was sent out. We had a close to 1 day virtual retreat. This all happened in 2021. A next survey was done, and we've been following up on the results. Since then, at the RA Task Force meeting, there's a white paper that we are drafting, and we are very thankful to the support of the NCI and CTAP and Karen Goodman and Kathy Yang for really making this a formal NCI branded publication and initiative. And so stay tuned for that publication and really getting those results out there. Next slide. So here's, I think Lisa's on, and we're going to kind of tag team this. Yeah, hey, Lisa.
Hey.
We have a very quick summary of open trials within the Nctn mechanism. I'll do the first one, and then there's 3 anal ones. One of them has been crossed off the list, which is successfully accrued, which is Adjuvant, Nivolumab in high-risk anal. So I'll start, next slide, please, with the AIM study, which is a big SWOG success when it comes to accrual. Next trial, next slide.
I can take this one.
Oh yeah.
Yeah. So SWOG S1820, it's an NCORE study. The PI is Virginia Sun and our GI champion, Stacy Cohen. And this is an actual study looking at rectal cancer survivors. You can see the N number is 94 or 47 per arm. And you can enroll these patients between 6 to 24 months after they complete treatment. They can have an ostomy or an anastomosis. And for enrollment, they need to have a low anterior resection score of 21 to 42. English speaking and 18 years or older. They have a short run-in where there's an intake and a food diary, and then they're randomized to intervention, which is a pretty in-depth coaching using AIMS resources, and it's given by the University of Arizona trained health coaches, so centrally administered, versus a control arm, and their main outcome is bowel function. Next slide. So this study opened in December of 2019. It's actually accruing very well, 71 so far out of a total of 94. But you can see the last 2 months it's dipped a little. So for those that have it open, please enroll. Next slide. Next slide. So now I'll go to the open anal trials. So this is an ECOG-led trial. The lead investigator is Jenny Dorth, but our SWOG champion is James Murphy. This is 2182. It's called the decreased trial because it's looking at lower doses of radiation in the chemoradiation paradigm for early stage anal cancer. So for early stage, these are tumors that are less than or equal to 4 cm, T1, T2, and 0. Squamous cell of the anal canal. They are randomized in a phase 2 trial design to standard dose chemoradiation, which is 50.4 gray, and then de-intensified chemoradiation, although we should call it radiochemotherapy since we're looking at radiation here, with T1s getting 36 and T2s 41.4 gray. The concurrent chemo is standard, and you can use capecitabine as well. The primary endpoints, 2-year disease control, They have some great secondary endpoints, including patient-reported outcomes, and enrollment to date is 41 over 252. Next slide. This is EA 2176. It's a randomized phase 3 of immune checkpoint inhibition with chemo for treatment-naive metastatic anal cancer. These folks are randomized to carbo and Taxol based on the INTERACT results that came out a year ago versus carbo, Taxol, and Nivo. The N number is 205, but it's a 2-to-1 randomization of experimental versus control. You can see the treatment schedule, and the primary endpoint is progression-free survival. The lead investigator is Kathy Ng, the co-investigator, also from Vanderbilt's Christine Sambor, and our SWOG champion is Van Morris. We have 31 of a planned enrollment of 205, and there is an amendment pending for small errors and collection of HPV ctDNA, and funding for that they just got, ergo the amendment from the Farrah Fawcett and Foundation and Sysmex. And they're also posting to Town and other advocacy support groups to help with enrollment. And please, if you don't have this one opened, we would love for you to do that. Next slide. We're going to go to developing trials. Next slide. So we have 4 trials in development. I'm going to tag team back with Dr. Koenneke in a second after I go over a new locally advanced anal concept. Our PIs for that are David Horowitz and Mei Choi. Next slide. So here's their proposed concept. So you just saw the decreased trial. That's for the early stage anal. And we just got the locally advanced anal that was open from ECOG looking at maintenance Nivo that accrued ahead of schedule and is closed. So we at SWOG are trying to work on the sort of next potential large anal trial. So this is a concept from our 2 PIs. It's for patients that have 4 cm or larger, or I should say larger than 4 cm or node positive locally advanced squamous cell of the anal canal. And then they're randomized to neoadjuvant before chemoradiation, chemoimmunotherapy with 2 immuno-oncology drugs, and then carbo and Taxol versus a combination immuno-oncology. And then after 2 cycles of that, going to go to sort of standard chemoradiation. However, again, with dual immune oncology drugs. The nice thing about this is an opportunity to collect longitudinal biomarkers, just as mentioned on the last one, HPV ctDNA. And for this, it looks like 20 per arm would able to provide us with a 3-month clinical complete response rate. We have that data from all of our large locally advanced anal canal studies. Next slide. So I'm going to turn it back to you to go over your own trial.
Thanks, Lisa. Appreciate it. This is a follow-up to the concept that we've been talking quite a bit about at SWOG, and for kind of logistic and PI affiliation reasons, this is a co-joint effort with a Carl Brown, a surgeon who was CCTG investigator. We're going to take this through CCTG. However, there will be plenty of involvement with US investigators. And just to summarize, this is really building on the NEO trial, where there's in one arm, patients are offered an induction of chemotherapy, transanal endoscopic surgery, and then patients are randomized to either, sorry, the randomization happens right at the beginning, but they are essentially randomized to chemoradiation if they do not downstage, or observation alone. and so that the primary endpoint will be 3-year organ sparing survival. Next slide. This is Stacy Cohen's study that also she has presented earlier in the working group meeting. And this is really asking the question with the objective of asking to do all patients need total neoadjuvant therapy. And this is a study for prospect-like patient populations that are treated with standard induction chemoradiation, then offered ctDNA, and then treated accordingly. ctDNA positive patients that are estimated to be approximately 20% will proceed to TNT therapy, whereas patients that are ctDNA negative status, there's really believed to be an equipoise as to whether or not TNT is required, and they're then randomized to either TME or to TNT, with getting 3 months, what will likely be 3 months of chemotherapy and then surgery. The primary endpoint is disease-free survival, and the estimated sample size is quite large. We discussed it earlier. I believe it was a little over 700.
Yeah, 720.
720. Next slide. And then finally, the Janus design. This is good news for the team. It does look like there's a pending approval, and the study is, in pending status at the GI steering committee. And we've seen some data that an estimated 80% of patients that get a pending designation are actually eventually approved. So I think the odds are that this will go forward. And this was also, we have Arvind Dasari, who is embedded in that concept and who has contributed a lot to it.
Okay, well, thank you very much. I think for the sake of time, we will just move on to our last but not the least presentation. And I have to say that Dr. O'Rourke has been sending messages about his enthusiasm to work with several people on patient-reported outcomes and quality of life issues. So keep him in mind. Moving next to Drs. Strasberg and Dasari, Neuroendocrine Subcommittee.
Thank you, Philip. And on behalf of John Strasberg and the entire Neuroendocrine Subcommittee, I'll present the slides today. Next slide, please. There are no major updates in terms of new data. Surufatinib, which is a VEGF TKI, is still pending approval by the FDA, and this is based on 2 phase 3 trials, placebo-controlled, that were done in China for pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors, and a smaller phase 1/2 trial that was done here in the United States. A lot of the ongoing trials in neuroendocrine currently are understandably focused around PRRT. As you all know, lutetium dotatate is currently FDA approved for all gastroenteropancreatic neuroendocrine tumors. And the ongoing trials are looking at earlier lines of therapy, such as the NETTER-2 trial that is looking at first-line PRRT versus octreotide. And this trial is limited to GEP-NETs, but also includes grade 3 well-differentiated neuroendocrine tumors, as well as grade 2 neuroendocrine tumors with a higher Ki-67. Other trials, such as the COMPETE trial, are looking at slightly different formulations of PRRT. And that's the COMPETE trial that's randomizing patients with GEP-NETs to lutetium edotriotide versus everolimus. And there's a phase 1/2 trial being led by Aman Chauhan, that's looking at combining lutetium dotatate with triapine in the same patient population. And finally, there is also a phase 2 trial of lutetium dotatate in other tumor types, that is para and pheochromocytomas as well. Next slide, please. Update on ongoing Nctn studies. So this is the randomized phase 2 study of platinum and etoposide versus temozolomide and capecitabine in patients with advanced G3 gastroenteropancreatic neuroendocrine tumors, as well as carcinomas. This trial was closed after an interim futility analysis. This trial was randomizing these patients to platinum etoposide versus capecitabine temozolomide. Don't have the final data, just have just the update that this is closed. So awaiting data from this trial. And Dr. Soares was the SWOG champion. Next slide, please. The Cabinet trial is a randomized phase 3 trial of cabozantinib versus placebo in advanced neuroendocrine tumors after prior progression on everolimus. Patients are being enrolled into 2 cohorts, pancreatic neuroendocrine tumor and carcinoid tumors. And they're randomized 2-to-1 to cabozantinib versus placebo. The PI of the study is Dr. Jennifer Chan from Alliance, and Dr. Strasberg is the SWOG PI. The primary endpoint of the study is progression-free survival. The study struggled with slow accrual for a while. And as a result, it was slightly modified, including liberalizing the eligibility criteria in terms of prior progression, as well as prior therapies, and also allowing crossover from the placebo arm to the cabozantinib arm. And seems like that's really worked because accrual has picked up with over 60 patients being enrolled over the last 6 to 7 months. The total enrollment for both cohorts combined is close to 400. Next slide, please. This is a newly opened trial that is looking at PRRT versus everolimus and well-differentiated neuroendocrine tumors that is being led out of ECOG and Alliance by Dr. Spada and Hope. Patients with lung carcinoids that are dotatate avid with prior progression will be randomized to PRRT versus everolimus. The study just opened for enrollment, and Dr. Hendefar is the SWOG champion. Next slide, please. This study is not being led out of the GI committee, but I did want to bring it to everybody's attention to try and help with enrollment. So this is a phase 2 trial evaluating temozolomide versus temozolomide plus olaparib for patients with advanced pheochromocytoma and paraganglioma, being led by Alliance by Drs. Perez and Del Rivero. And this is randomizing eligible patients with para and pheochromocytomas with progression 2-to-1 to temozolomide plus olaparib versus temozolomide alone. The combination arm will also have olaparib maintenance after initial combination therapy. The primary endpoint is progression-free survival. It's been open for about a year, but due to multiple factors, it's has been slow to enroll. So if this trial is open at your institution, please consider enrolling patients. Next slide, please. So you've already heard about this trial from Dr. Soares that was just opened yesterday. This is an older version of the trial and has undergone a few modifications, But just to quickly highlight again, this is a phase 2 trial of post-operative adjuvant capecitabine and temozolomide versus observation in high-risk pancreatic neuroendocrine tumor patients. And about 145 patients will be randomized 2-to-1 to capecitabine temozolomide versus observation. And the study is open as of yesterday. Next slide, please. Next slide. This is a trial in high-grade neuroendocrine carcinomas that is being led by Drs. Zen and Chiorian and the GI committee in collaboration with the Rare Tumors Committee. And this is a phase 2, phase 3 study of first-line platinum and etoposide with or without atezolizumab in patients with poorly differentiated extrapulmonary small cell neuroendocrine carcinomas. Patients will be randomized to one of 3 arms, including platinum etoposide followed by observation, or platinum etoposide plus atezolizumab followed by observation, or the same treatment followed by a maintenance therapy with atezolizumab with the primary endpoint of overall survival. We hope that this trial will be activated very soon in the next few weeks. Next slide, please. This is my last slide. This is a trial that came out of the neuroendocrine CTPM that we just had a few months ago. And this is the first concept that is approved and moving forward. And there are potential other concepts that may follow over time. So this is being co-led by SWOG and CCTG, with the SWOG PI being Dr. Aman Chauhan. And this is looking at a retreatment with PRRT in patients with small bowel neuroendocrine tumors who have received prior PRRT and have had some benefit defined as at least 12 months of stable disease or response post completion of PRRT. And patients will be randomized to retreatment with PRRT versus everolimus with a primary endpoint of disease-free survival. And we estimate that there'll be about 126 patients needed for this trial. And this concept will go to the GI steering committee soon. I believe that's my last slide.
It is your last slide, and thank you very much. We are just 1 minute past the hour, or even not. Actually, we have 1 minute to go in 3 minutes because we started 2 minutes past the hour. I don't see any questions, but I have a comment. The study olaparib plus temozolomide, we have Dr. Charlie Lopez, who's the SWOG champion, just to mention that. And the question I have is, surfatinib is going to be available when in the United States, and how is it going to be affecting clinical trials?
I was not sure. I think
maybe you can give a bit of a couple of sentences about surfatinib so people know, and then let us know what do you think of its availability. So
surfatinib is multi-VEGF TKI, but also has activity against CSF1R and FGFR. It was developed and evaluated in China, including in 2 large placebo-controlled phase 3 trials, one in pancreatic neuroendocrine tumors and the other in extrapancreatic neuroendocrine tumors. And both trials were stopped after a planned interim analysis showing benefit. The initial plan was to do a randomized trial outside of China, but after meetings with the FDA, They were willing to accept the data from China, in addition to just a dose-finding study here in the United States. And that data was presented in multiple meetings, showing good tolerance and with limited sample size, about the same activity as well. So in terms of how it may change the clinical trial portfolio, if it is approved, it would be the first VEGF TKI that would be approved for extrapancreatic neuroendocrine tumors. For pancreatic neuroendocrine tumors, I think sunitinib is already approved. Whether the FDA would approve it before or after is uncertain. But at least in the phase 1 trial that we did here, we did notice activity even in patients who had received prior sunitinib or everolimus.
Okay. Thank you very much. This concludes our GI committee meeting. I'd like to thank everyone, and specifically the presenters, speakers, and the subcommittee chairs, and staying on time. Thank you. Have a great weekend, and see you in Seattle. Obviously, we'll see you before that in San Francisco for ASCO GI, and but if we don't, then see you in Seattle. And for the working group people, we're meeting every month, but we're not going to have a meeting this month. So our call for the 4th Tuesday is canceled. Goodbye.
Thank you.
Thank you.
Thank you.
Thank you.